Hey, this is Miss Pullum, and this is going to be your. Do this again. You need 'em. So there are different phases of the surgical care for clients. So you have basically three stages. You have the pre-op stage, the preoperative stage, the intraoperative stage or preoperative or phase, or the postoperative phase. So the preoperative phase really starts at the point where the patient decides that surgery is going to happen. Um, so this is all that nursing care that happens at the point where surgery is decided upon up until the point where the patient gets placed into the operating room. So this is that preoperative phase. Um, so when we are talking about this, which is what this PowerPoint presentation is mostly focused on, this is the nurse's role, the patient's management, that patient care management within that phase. And then your next phase, which is that intraoperative phase, we're talking about the patient management within the operating room. And within that, while we're talking mainly about the nursing role and what that entails, you still need to be aware of the different roles that other people play, because the nursing care kind of relies on these other roles. And some of the nursing care, while they're not the manager or the boss of those care, they do have to work interdisciplinary with those other roles as well. And then the other care is that post-operative phase, which is actually quite a long phase of care. And a lot of times we think of that post-operative phase as that PACU, that post-anesthesia care unit, which is that as soon as they leave that OR and they go into that recovery unit, post-anesthesia, PACU. And a lot of people think of it as, when they're recovering in that outpatient center or if they're on the floor, but it actually continues even after the patient goes home. So sometimes it's home health nurse, sometimes it's that care when they're returning to see their physician, sometimes it's care when they come in for outpatient procedures because they need follow-up care. But that post-operative phase actually continues all the way up until they're released by their surgeon. So usually it's like a 6 to 8 week kind of plan of care. Sometimes patients are actually released in 1 to 2 weeks because they're very small procedures, but it can last quite a bit of time, that post-operative phase. So it actually lasts a bit longer than a lot of people realize, because that post-operative healing phase is part of that post-operative phase. And so that whole patient management phase, there may be multiple nurses involved in that phase of care. This is more of just kind of an FYI type surgery. I do want you to know it. I think it's important that you kind of understand the difference between why are people having surgeries. If you're having an ablative surgery or an ablation surgery, really what's happening is you're just having surgery to remove a piece of tissue or a small tissue from an organ or part of body. So you're not removing a large area of tissue or a large part of your tissue. Typically, you'll see this in something when you hear someone say, oh, I'm having an ablation or a removal. What's happening is they're going in and they're just taking a very small area out. And it's typically something like a laser or like a fulguration or something where they're going in and removing something that's causing some kind of abnormal action to happen. So you may hear it if you're having maybe like an abnormal heart rhythm. You may hear like a cardiac ablation, where you have an abnormal cardiac rhythm, where they go in and they just kind of remove the part of the heart that's causing this abnormal rhythm, and they have an ablative surgery. And cosmetic surgery would just be to change or revise an area of structure of your body. So, it's referred to as a plastic surgery. It could be something like a nose job or a facelift. It could be breast augmentation. So all of those would be different types of cosmetic surgery. You could have a curative surgery, would be something like, could be a mastectomy, where you remove a breast cancer. You remove a whole breast to do a mastectomy. or it could be something like a appendectomy where you're removing the inflamed appendix. It could be a diagnostic or explorative surgery where you're actually going in to try to identify what's going on because you're not sure what's happening and you're trying to figure out what's causing like pain or whatever symptoms the patient is having. You could go in and have a palliative surgical procedure where you're going in and trying to cause decrease in the pain or symptoms that the patient is having. You could have a reconstruction or restorative procedure where you're trying to, for instance, if you were trying to reconstruct, it could be something like if you had that mastectomy and you wanted to reconstruct the physical appearance of that breast, you could have a reconstructive surgery to reconstruct that appearance, or you could restore something. It could be something like if you had somebody that had a colon cancer and they had an ostomy in place, you could restore that and take the two sides of the colon and then restore that function by putting those two colons together. So reconstructive is typically more of an appearance, whereas restorative is often for more functional purposes, typically the reasoning behind that. And a transplant, I think you can probably figure that out, that is, an organ transplant, but it isn't always just a kidney or a heart. That a transplant can be something like a cornea as well. In fact, my husband has a cornea transplant from that he's had for 10 years that restored his vision in one of his eyes, and the other eye he's legally blind, but in one he can see really well from it. Okay, so these are also just common suffixes that you might see tacked onto different type of surgical procedures, and this is why they would be added to the procedure. So if you see the word ectomy, it would be to remove, raphe, repair, ostomy to open, otomy to cut into, plasty because of a plastic type of repair, scopy because you're looking into it using a type of scope camera. When you talk about the different locations of surgery, this is just more of just for your information. You may have an ambulatory or an outpatient surgery. You do not have to be in a separate facility than a hospital. You can have a hospital surgical procedure that is still an ambulatory or outpatient procedure, and you can have an inpatient procedure that started out as an ambulatory procedure, and you see that with a post-operative admission down here. And then telesurgery or robotic, they could still be done inpatient or ambulatory, but the telesurgery or robotic procedures, it's just kind of thrown in there to tell you that the physician themselves doesn't necessarily have to be in the OR suite with the patient, but often they can be in the suite with, or they could be outside of the suite, but in actuality, they don't necessarily have to even be in the same hospital or the same facility as the patient with the technology that we have. There are also a lot of times that patients will come in, through the emergency room, and they come in, they have an emergency surgery, they may be admitted after, or they may even go home after. I have many times as a circulator came in, had an emergency surgery happen, and after the surgery, because it wasn't a very invasive surgical procedure, and like it may have been an esophagogastroduodenoscopy or EGD, where we did an upper scope. What had happened one time, for example, a patient had safety pins in their mouth while they were trying to pin some curtains, and they swallowed them. Well, they got stuck. They were not, that was not a great thing when they got stuck. But however, once we were able to go in with an EGD and get all of these out, then it was not an issue any longer. The patient just needed a couple hours. They had recovery. We did the scope. They had recovery. We needed a couple hours of observation, and then they were able to go home. It was not as severe, so they did not need to be admitted, so they were a post-operative discharge. Most of the times when we did have emergency surgery, they do end up needing admission, but in that case, it was an emergency, but they no longer needed admission. So it doesn't typically happen, but it can occur. So this is just kind of to show you the different degrees of urgency and really where this falls into kind of being an issue. I'll kind of talk about that in a second, but you have different degrees of urgency of surgery. So for the most part, your surgeries really fall in the spectrum where it's going to either be like super urgent, or it's kind of urgent, or we can put it off for a little bit. You don't actually have to have the surgery, but you probably should, or you have to have the surgery, but it can wait for a while. So an emergency surgery means like, hey, if you don't have this surgery kind of like right now, you could possibly die. Basically, it's a crass way of saying it, but that's literally how it is. If in reality, if you don't have this surgery, it is life-threatening. So there may be a trauma, they may have had an MVA, motor vehicle accident. So there may be a trauma. So we need to go in there and repair something because there may be bleeding or something that could cause infection, or like a rupture or trauma, something that causes infection that could possibly kill them if we don't fix it. So I'm going to use the example of a ruptured appendix. So in most cases, an appendicitis would be an urgent surgery that we would need to get in there relatively quickly, but often we don't have to get in there within like a half hour to an hour because it's not ruptured. But once that is ruptured, it becomes an emergency because it could potentially be bleeding, and it's an infective issue once it gets in that peritoneal cavity, because our bowels have ruptured into peritoneal cavity. It puts the patient at risk of peritonitis, which puts them at risk of septic shock. So it becomes an emergent issue once that's ruptured. So that is a limited time for that patient to prepare, and you would want your on-call surgery crew to get in and get that patient in immediately, and their life could be potentially at risk. However, if that appendix has not ruptured and does not look well, and is not on the edge of rupturing, so it kind of borders sometimes, you typically have a good day or two. Now, typically you don't wait a whole 24, 48 hours because you don't want to let it get to that point, but you can usually wait at least about a day, give them some antibiotics to let that get into their system, make sure that they haven't eaten for 8 hours so you don't have to worry about aspiration, make sure their chart is in order, make sure that the OR is prepared, and it allows everyone to prepare, family to get there, everything to be in order, and the patient is ready. So it's still urgent. You don't want to put this off too long because that appendix could potentially rupture if you wait too long. So it is an urgent surgery. You don't have an appendix that is inflamed. Often it's just not going to repair itself. You need to go ahead and get that ready to go. There's really not much more you can do once it's decided that it's ready to go. So that's an urgent surgery. You need to get it going. Now, there are other surgeries that are either going to fall on elective or required depending on what's going on. So most of the time, if the surgery is most likely not going to cause harm to your life or cause a risk of death, it's going to be elective. And most of the times you're thinking things like they cause pain, and they can cause issues with your quality of life, but they do not cause physiological damage to your health. So think like hip replacements, some things like hysterectomies where they may cause ongoing bleeding, but it's manageable. So like fibroids, things like that, but you can manage the the symptoms with other treatments, and it typically is not life-threatening unless it gets really, really severe. So the surgeon may say, you know, I really am advising that you get this taken care of within a few months, but you know, ultimately it's up to you. This will be an elective surgery. Typically, you have 3 to 6 months to prepare for that, and it gets scheduled. Whereas a required surgery would be something like an inflamed gallbladder with gallstones. You probably have several months before this would be to a point where the physician would be worried that it could cause a problem bad enough to cause an issue that could be life-threatening. But eventually it could get bad enough to cause that issue. So like a gallbladder could potentially cause a common bile duct flow, when I say block your common bile duct flow, which could cause some really bad symptoms and could, you know, cause some really severe symptoms and could cause some life-threatening symptoms if it was left to go on too long. And then also infections and things like that. So a physician would say eventually, this is going to be a required surgery. You need to take care of this. So they would say you would have to get this. So that would be the difference between elective and required. This one would be eventually life-threatening if you did not take care of it. Okay, so there are different levels of risk of surgery. And once again, you cannot, by any means, memorize all of the different major surgeries or minor surgeries or any of this. But you should have a general idea that something like a heart surgery would be a major risk, and something like a colonoscopy would typically be a minor risk, and somebody who is an elderly patient with heart disease would probably be a higher risk than a 20-year-old with no other health risk. So the more health risk you have, the more risk you would be. So that makes the surgery higher risk. The longer the surgery is, the more risk it is. The more anesthesia, the higher risk. The more prolonged, the higher risk. The more invasive, the higher risk. Yeah, that's pretty much. So the more invasive, the longer, and the more anesthesia. So the more invasive, the more anesthesia, the longer the surgery takes, the more comorbidities, the increase in age, and let me see if there's anything else. The length and severity of the procedure. I think those are the main things that you really need to know. And then there's different types of surgeries as well. So you can either have an open incisions, there's laparoscopic procedures. You can have procedures, there's procedures that can be vaginal incisions, like hysterectomies can actually be vaginal incisions. Like we talked about robotic surgeries. There's ablations, there's laser surgery. So there are all types of different surgeries that you may be exposed to during them as well. Okay, so we're actually at the part where we're going to talk about some pre-op stuff. So that's fun. So the pre-admission testing starts once again when we first decide we're going to have surgery. So we're going to begin this at the physician's office. So that nursing process starts at the very beginning, and teaching begins as soon as that surgery has been planned. So we start teaching about what to expect with the surgery, what's going on. The physician themselves should be telling the patient at this point the risk and the benefits of the surgery and what to expect. So before this patient ever gets to the surgical center, all this information is being discussed with this patient by the surgeon. And all this testing and all these things are kind of getting ordered at this point. So a lot of times, a lot of this pre-testing, this pre-education, all this stuff is being done a long time before they ever get to the surgical center. They on the admission date, we'll have demographics. There's usually a health history. We'll get other pertinent information about the surgical procedure. We'll usually get history to anesthesia, history of anesthesia. Often this is done prior to them ever coming into the surgical center. A lot of times what you'll see, and if you've ever been to surgery, you've probably been through this as well, where you go in and there's like this pre-operative stuff that you go in and they're like, here, we got to go through this surgical checklist and this and that, and it's your pre-operative stuff that you need to go through. And then that's usually with bigger surgical procedures, and sometimes with smaller ones, you just come in the same day. And with different surgeons, with different facilities, it varies. But there's always going to be this collection of the health history and the surgical history and the anesthetic history and this demographic information. So always, 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 we need this information. And it gets verified the day of as well. So we still have it collected the day of, or we verify it the day of. So it's still looked at the day of, even if it's collected before. So the verify completion of preoperative diagnostic testing typically is done either prior to or the day of, but it's also going to be done during when they're at the surgical center as well. Discharge planning begins before they ever get to the OR as well. So even before the surgery is taking place, we're thinking about how they're going to do once they go home, because we need to have everything planned. You don't want to go in, have a patient in the OR and then be like, oh crap, we don't know how they're going to do when we go home. You want to know what the plan is for taking care of them when they go home. So when they get admitted to the surgical center, one of the very, 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 very important things, and one of the things we'll talk about in an upcoming slide, and when we get there, pay very, very, very close attention to it, is informed consent. So informed consent. Now, ultimately, the informed consent, the information about it, what the patient knows about it, the education part of it is the responsibility of the physician. So the surgeon gives the patient the information. They are providing them the information. So the informed part is supposed to be the surgeon's responsibility. So they inform the client, right? So the nurse, however, needs to assess their education. So they need to assess their knowledge level. So they reassess that, you know, are they informed? Hey, let's assess their knowledge. We reinforce the education. So we don't inform, we do not provide that informed consent. We assess and reinforce. But our responsibility for informed consent is to make sure the right person signs that form. And we will talk about that later. We'll do the perioperative assessment. So we're going to go in and do this full head-to-toe preoperative assessment. We're going to evaluate their system and make sure that they're healthy and ready for this surgery. And of course, there's going to be people that have comorbidities, but we're going to be assessing that and checking on that and communicating with the operative team and making sure that everything is known and is established. We're reinforcing that once again, reinforcing that informed consent education, and we're reinforcing that post-operative education. So all those complications that can occur post-operatively, we're going to reinforce that education on how to prevent that. So the turn, cough, deep breathe, incentive spirometer, the splitting when you're coughing, meditation for pain control, the PRN pain medication, ask before it gets too bad, what is your preferred level of pain control, make sure that you ask before it gets down to that, you know, before it gets, or when it gets worse than that, or before it gets worse than that. I like lost my brain for a second. The SCDs, what to expect post-operatively, what you're going to wake up feeling, and then we'll be talking about, of course, we're talking about the pre-op stage and what we're doing and the taking off the metal. And so all this stuff that we're going to be talking about here, all this stuff gets educated on. Of course, they've been educated on this from the beginning, and we're just reinforcing that, and then we just continuously educate throughout this whole process. And the reason why it's so important to do this education in its pre-op stage is because if you wake up from a surgery and you have wounds all over you, you're groggy, you've got pain medicine on board, you're hurting, you don't feel good, you are not going to be able to hold in all this information at that point. So it is so important to get this information started at a point where you're able to hold it, and then all you're doing is reinforcing it at the point where you're hurting and groggy. So it's not new information, it's like reorienting a confused patient is much easier than trying to start brand new information at that point. And then the holding area of the pre-op phase is really the point right before they go into the ER. And so they've already done all this, like getting the chart ready, getting the consent, making sure the H&P is on there, making sure the labs are done, checking everything, doing all the communication, making sure everything's ready to go. And so in the holding area, we're reviewing all this and making sure once again. So it's like this final check right before we go in the OR. Let's review that medical record. Let's make sure that consent's on there. Make sure that OR consent, that anesthesia consent, that H&P must be on that chart. Every patient has to have an H&P on that chart to go in OR. The only exception is those emergent patients, because obviously saving their life is better than an H&P. Make sure that IV has been started. Make sure that it's patent. Make sure that the IV site looks good. Verify the surgical site has been marked prior to them getting there. Make sure that it's all checked and it's the correct one. Check it against the consent. And then that communication, you keep that established as well. Okay, so there are some factors that are going to affect surgical risk, and you're going to hear time and time again, if you're elderly or if you're very young, so very old, very young, you're going to have an increased risk for almost everything. So with older adults, it's because things wear out or because you have a bunch of diseases, and I'd say a bunch of diseases, but you kind of just develop comorbidities, kind of like Pokemon, because as you get older, you're exposed to more, you've had this buildup of diseases that has developed over time just because you've had the opportunity to develop it. So over time, you've had things like cholesterol build up in your vessels, you've had arterial changes, you've had diminished liver functions, diminished kidney functions, you have less physiologic reserve and metabolic abilities, so you are more prone to hypothermia and temperature intolerance. You may have less ability for your respiratory reserve, so you may have more respiratory complications. You may be more at risk for cardiovascular complications, so they have to be very careful with monitoring, or we have to be careful and monitor cardiovascular systems more carefully. We do have to be careful and monitor the temperature more carefully and make sure, warm blankets, things like that have to be given to older patients often. They do get very cold very easily, especially with surgery. They often need increased blankets and or warmers in surgery, especially with longer surgeries. They may even need warm fluids depending on what's happening, what's happening with them. They also have decreased subcutaneous fat often. And just in general, they often have a lot of more comorbidities, so that just needs to be taken into consideration when they're in the OR or when they're going into the OR. Infants and children are kind of the opposite reason. They're often less mature, so they haven't really had the ability to develop as well of a regulated system. So often they definitely have ineffective thermoregulation, especially infants. Children often aren't as bad, especially once they get past that toddler stage. They aren't really that bad with thermal regulation, but both infants and children do have limited circulating blood volume, so they do have less of that. So it is more risky if they lose blood volume. So you do have to be very careful with that, monitor that very closely, and just be aware that even less blood volume or blood loss can be a high risk for circulatory collapse. So that needs to be watched very closely as well. So Anyone that has a nutrition or fluid electrolyte balance is going to be at a higher risk for surgical complications, because it can delay or poor nutrition can delay wound healing. You need proper nutrition in order for wounds to heal well. So they're going to be, especially post-operative, at a higher risk. So that's something that you need to know going in. And that negative nitrogen balance from the electrolyte balance is also going to increase blood glucose and can break down protein. The surgical trauma can increase the blood glucose and break down protein. And obesity itself, while obesity is also kind of linked to other comorbidities, one thing that we see with surgical patients is it's going to be linked with problems with post-op ventilation. If you think about what happens, is that weight of the patient itself puts that pressure on the diaphragm, and it causes a increased effort needed to get the same ventilation as it would with someone that did not have that obesity. And also on top of that, because of the adipose tissue, it requires more effort for circulation. So it limits that circulation due to the adipose tissue. So they have that problem with ventilation and circulation as well. So the obese patients are already at a increased risk with surgery. On top of that, during surgery, they may be at increased risk, especially depending on what type of surgical procedure they are, with different positioning as well. So that needs to be thought about in that pre-operative phase and then communicated with the surgical team. So the many factors can affect surgical risk. Obviously, if you have comorbidities, you're going to have less reserve in different systems of your body. If you have cardiovascular disease, your circulation is going to be decreased, or your circulatory system is going to have decreased function. Your lung disease as well. If you have lung disease, you're going to have less reserve in your respiratory system. It's also important to note that if you regularly use nebulizers, or if you have a history of constricted airway disease, that the nurses would usually note that, because a nebulizer would typically be used just before entering the OR and just before or just after leaving the OR as well. And typically that would be discussed with the surgeon and the anesthesia, and the anesthesia would be informed of that. Often they'll be involved in that ordering that nebulizer as well. And then also it's important if somebody was on corticosteroids recently, because there is a risk if that was stopped suddenly because of adrenal insufficiency can occur, and especially with the use of anesthetics can cause that insufficiency to happen as well. Kidney dysfunction and liver dysfunction can cause metabolic issues with the metabolism of medications, which can be an issue in the OR with anesthesia, and it can be an issue post-OR, especially with things like opioids, and it gets even more complicated if you have older adults, because they already have slower metabolism. So it can be a problem that can build upon itself. So it is something that needs to be both communicated and both with the surgical team, and something that needs to move in with the communicated as it continues into the surgical team and in the post-operative care plan. Anybody that has any kind of coagulation disorders, high risk of bleeding, or anyone that is on coagulation medications like anticoagulants, antiplatelets, anything like that, we need to make sure that they have stopped those in time. Anticoagulants need to stop at least 5 days before surgery. Antiplatelets, like aspirin or clopidogrel, like Plavix is the brand name, would need to be stopped at least 7 days before surgery. If you have a patient that has a decreased immune system, now this could be someone that was on corticosteroids for lung disease, or it could be somebody that has a disease like HIV, or another, if they have chemotherapy treatment, or if they have an anti-inflammatory disease and they're on another immunosuppressant. Any reason, if they're on a decreased immune system, they're already going to be at increased risk of infection because they're in the facility, but they're going to be on an increased risk of infection because of the surgery. So there's a lot of reasons that could be a problem. If they have allergies to things like iodine shellfish, that could be a problem because of some of the antiseptics that they use in the OR. That could be a problem with some of the testing that they use, like the contrast in CTs. But also allergies like latex is a major concern and needs to be a major alert, because while we try to get away from latex a lot on the floor, there are still a lot of surgical equipment that still use latex, and even the ET tubes and things like that, there are a lot of latex, and that usually they'll try to take the latex allergy patients and keep them till the end of the day so that there is no cross-contamination possible. And they will give them a special latex kit, and they have special latex equipment, or latex-free, not latex kits, latex-free kits that they use specifically for patients that have latex allergies, so that they are able to not contaminate them and cause any kind of issues with them as well. But it's very important to make sure that that is communicated with the OR team, and then that continues in with the post-operative phase as well. And then, of course, here's more of the surgical risk where we continue to talk about the medications. Of course, with the anticoagulants, that's going to slow down the process of making the clots happen. Once again, if you have on an anticoagulant, at minimum, we need a 5-day stopping. The antiplatelets, we need a minimum of 7-day stoppings, and that's going to stop the platelet aggregations. And so that's 7 days. Typically, you're going to see the physicians ask for a minimum of 7 days to 7 to 10 days stopping from that. So if you ever hear somebody come in and say that they're on these and they haven't stopped that, that's going to be one of those instances like, oh crap, we may not be able to do this surgery. So that's one of those, let's stop in our tracks and fix this right now. So that's one of those, whoop, stop what you're doing and get this figured out immediately, because that would be those, hey, this might be a contraindication to the surgery. Also, patients on those, even when they stop them, even when they've stopped them like they were supposed to, often you will have to get the labs to make sure that their levels are where they're supposed to be. So when patients are on, warfarin, you're going to be looking at an INR. If a patient's on like heparin, you're going to be looking at a PTT. So you're often looking at labs to also be looking at those. If you are on antidepressants, sometimes that can change the way that anesthesia is metabolized. If you're on tranquilizers, sometimes if you suddenly withdraw that, seizures can happen. And this isn't always just like, oh, they held it one time because of OR. It's not necessarily that is that major of an issue. We held it one time for the day. It's very important for this to be continuously reported both to the OR and as the post-op, because sometimes if these get held post-operatively, we find out that a patient's meds did not get continued, and then a patient could potentially have these seizures post-operatively. So this medicine, we need to know all of these medications, both so that we know for OR reasons, and we need to know these for post-operative so that we don't have these side effects happen there. With diuretics, patients that are on diuretics, there's always these risk of the fluid and balance and electrolyte levels, and so that's always something to watch for in the labs. We talked about the corticosteroids, and we never want to stop those suddenly. So often if a patient's on these corticosteroids, especially if it's something for an endocrine issue, we never want to stop that suddenly. So these patients may need to be switched over to an IV corticosteroid. So if you have a patient that's taking those regularly, you do not want to stop that suddenly. So that would be one of those things where we're looking for an alternate route of medication. If a patient is taking, having surgery, typically it is nothing by mouth at all, for at least 8 hours or possibly 12 hours prior to surgeries. But often if they're taking blood pressure or cardiac meds, they will tell them to go ahead and take those, because you don't want to take a patient that's having surgery and say, okay, well, I'm just going to put stress on your heart and I'm going to put stress on your cardiac system and then put more stress on your body. So typically, unless there's something else going on, unless I give you more information, you will still give them blood pressure and cardiac meds. So yes, give them cardiac blood pressure medications day of surgery, even if they're NPO, unless there's something that tells you to hold it. Okay, so you'll see a whole bunch of lists on these herbal products, and I by no means am trying to get you to memorize all of the herbal products, because this is just kind of a small selection of some very common ones or some that are well known. So ephedra, in fact, ephedra itself, I'm not even sure if it's back on the market, but ephedra was one that was just really, really common for a while. For people were taking it to lose weight, and they were crazy about it. They were like, oh, I'm losing weight, and it gives me so much energy. And then people started dying from heart attacks because they were having electrolyte imbalances and cardiac dysrhythmias because of misuse and things like of that nature, and because the medication, or it wasn't a medication, it was just an over-the-counter unregulated herbal product, and people were taking it without consulting their physician, and taking it was having side effects and things of that matter. So it has a risk of cardiac issue and electrolyte imbalance. Feverfew, which is a medication that can help with migraines for some patients, can also increase bleeding risk. Ginkgo biloba has been used to increase memory. Garlic over the counter has been used. I can't remember what it's used for. I think it's for inflammation. It also increased bleeding risk. Vitamin E for immunity, but it also has been shown to help with skin care and such if you take it orally. It also increased bleeding risk so much that you have to stop it, I believe, 2 weeks before surgery. Kava, which is used to increase relaxation, can be cause liver toxicity with some of the anesthetics used in OR. Ginseng for energy and immunity can cause cardiac problems, or can increase cardiac effects. Let's see what else. Did I go over all these? I thought there was some more on there, but these are just very common things that we see, and these are herbal products. So really the main thing is I just want you to see even these very common things that a lot of people are on, and they think they're very innocuous. I know a ton of older people that are on ginkgo biloba, but it can increase bleeding as well. Just remember to get a very thorough history, including over-the-counter medications, because for one, NSAIDs can increase bleeding, and their herbal products. Do not forget that herbal products, things that they take like vitamins and herbs, are important and can be a cause of side effects and contraindications to the OR, and it must be discussed and looked at as well. it's important to look at illegal drug use as well, and it's important to go into it and make sure that the patient knows that you're looking at it in a non-judgmental way as well, and just let them know that it's important to know that because it increases the tolerance to anesthetics and analgesics, and it's just important to know for that purpose alone. Any alcohol use can potentiate the action of anesthetics and analgesics as well. It's important if there's any use of alcohol that we know if it's in the system. So if there's any history of alcohol use, you want to go ahead and get an alcohol level. If the patient has a history of alcohol abuse, it's important to know that because we need to watch them for withdrawal. And we start seeing those symptoms about 24 hours after they have their last drink. And those withdrawal symptoms we want to watch for very closely. We're going to start seeing elevated heart rate, elevated blood pressure, and we can start seeing tremors, anxiety, and then we're going to start seeing other risk factors. They can actually start having seizures, etc. And this is not an alcohol withdrawal lesson, so we're not going to go farther than that, but it's important that we know 24 hours and then we start watching for those symptoms. Oh my gosh. Okay, and of course smoking is going to affect your surgical risk because it is going to affect your respiratory system. It can increase your respiratory complications. It can also constrict your blood vessels, which is going to cause cardiovascular risk, which can cause poor circulation, cause wound complications, and delayed wound healing. If you have a patient that has a decreased mental status, either due to previous issues or issues that have happened during, I guess it's going to be, we're talking about pre-op, so if you have a mental status issue, that's going to interfere with the ability to understand the teaching or to give consent. And then the consent issue, that's going to be an issue with trying to identify the right person to give consent, which we'll talk about. With emotional health, a lot of times, if a patient doesn't have good emotional health, that's going to increase that anxiety and those feelings of unease, where a lot of us are, it's a common reaction. If you're going into surgery, if you're having procedures, it is common to have anxiety. It's common to be worried. That's normal. And if you have emotional issues, or if you don't have a good ability to cope, or you have poor emotional health, you're often not going to express your emotions in a great way. So you may see patients that are angry, argumentative, demanding, overly critical. And I just want to kind of put in this kind of use your nursing process. So I don't want to say, let patients abuse you. I am not saying that, because patients do not have the right, especially patients that are alert and oriented, they do not have the right to be abusive to you. Now, that being said, sometimes, because patients are going to be a little cranky, a little angry, and a little argumentative, but that being said, patients are going to not always react exactly in a kind and wonderful way. And we do have to give them a bit of grace, because they are at their worst, and we are there to treat them at their worst. So no, you should not sit there and let a patient who is completely with it and alert and oriented, especially in the pre-op phase, if they're not having a wound and they're not in severe pain, they should not be able to just abuse us. That's not okay. But what I am saying is, use your nursing assessment and see if you can identify what's going on. Are they hurting? Is there something that we can educate them on? Is there something that they're upset about that we can fix or that we can mitigate? So often it is something little that they are in this high stress situation, and because they either don't have the coping skills or because they just have gotten so anxious that they have made it such a big catastrophe, or they catastrophized the situation, they're not able to get out of it without help. We are able to fix that for them with just a little bit of help, you know. So if we go in there and calmly validate their feelings and help and say, wow, I am so sorry that you're dealing with this. What can I do to help? Sometimes that little bit is enough to calm them down. So while it sucks to go in and be that nurse that has to deal with that patient, sometimes you can be the nurse that has to deal with that patient, and then you're the nurse that they love. And I know this because I have dealt with the patient that's cussed me out and that been the nurse that they loved every time since. And I know that it sounds terrible to have to deal with that, but like, well, I don't want to say they cussed me out, but they were cussing into the wind. They were not cussing me out, or I would not have dealt with it. But so that's all I want to say about that, and I'll move on from there. All right, so now we're getting into some of the interventions that we're actually doing. So preoperative nursing, what do we need to do? We need to collect all this patient information. So we are collecting so much information. So a lot of what we're doing is we are getting all the stuff that we need to have and know and be available and check before we get this patient to the OR. So full health history, it better be on that chart. So the physician would have gotten a health history separate from this. They've done their own health and physical. And like I said, that will be on the chart before they go into the OR. But we're also collecting a health history, a nursing health history. There's usually a spiritual and cultural history as well that's along with that. And sometimes that spiritual and cultural history will identify things that they believe in, they do not want in their treatment options. For example, some people do not allow blood products. You know, we talked about back in the blood product lesson that patients like Jehovah's Witnesses that are very devout, they will not accept any blood products. So that would be super important that, hey team, you are not going to give this patient blood products, which would be super important. We would not be able to get the consent for the blood products, this patient going into a surgery if they were having like a major bowel resection, them not having a blood product would be something that we would need to know prior to going in there, and would be something that the physician may not feel comfortable, stepping into that procedure without another plan in place prior to it. So that could be something that would stop the procedure from happening. Whereas another thing, another cultural or spiritual procedure that we would do could be something as simple as, they want, some object to be in the OR that is not, that they feel like would just keep them peace or something, and it would be something that we maybe would be able to facilitate. Something when you're trying to do something with them, you just need to make sure that it is safe and it does not cause harm and it's feasible to do. Those are the things that you need to take into account. Of course, we need to perform a full physical assessment of the client. If we find any abnormalities that are concerning, it needs to be reported to the rest of the team. We want to do a mental and emotional assessment as well. We want to assess the knowledge of the surgery and the perioperative care. Of course, once again, with the surgical procedure itself, the physician is the one that has given the information for the informed consent, and we are really just reinforcing it. The perioperative care, the patient would have been doing the preoperative washing with the antibacterial soap, usually prior to coming to the pre-op facility. Sometimes, depending on if they are inpatient or not, the preoperative nurse may be the one that is performing that pre-op care. Like say it was a bedridden patient, the pre-op nurse may be the person that is providing that preoperative care as well. Perioperative care may be using the clippers to what I would say, prep the IV site, or not IV site, the surgical site as well. If it needs, you do not shave a site, you only use clippers, because if you shave, you can cause small nicks in the skin that could lead to infections. You want to assess the patient's coping strategies and their support systems that are available for them as well. And then you, of course, want to identify those risk factors that affect the surgical risk, and we kind of talked about a lot of those. And then those allergies that we talked about, of course, to meds and iodine, latex, etc., that we talked about. One of the other things that for latex, if a patient is allergic to bananas, like if they've never been around latex, but they are allergic to bananas, it's important to note that, because that is often across allergies. So if they're allergic to bananas, they're often allergic to latex. So it's important to note that, because it's something that the team needs to be aware of. Okay, so in my opinion, this is the most important thing for preoperative nursing care. And legal consent is just such an important thing. If you don't have this on something, it can bite you in the butt so hard. All right, preoperative nursing care, obtain legal consent. So first of all, the surgeon is the person who should be providing the information for the client for informed consent. So you will describe the consent procedure to the patient. You will ensure the patient meets the requirements to give the consent, which means they are the legal person who should be signing. You will obtain informed consent. And this is if you're the pre-op nurse, right? So they will sign the consent form, or they will sign the consent form because they're the right person, and then you will sign the consent form after them as a witness. And what you are saying when you witness it is that they are the right person who can legally sign and give consent. So while you are not the person who has given them all the information, you should still go back and reinforce that education. And if the patient just doesn't understand anything, you should not be getting consent. Like, I mean, you should be like, hey, you don't know what procedure you're having at all. You don't know any information. You should be calling the physician up and being like, this patient has no idea what's going to happen to them. They don't understand any of this. The physician should be getting the consent in reality. So what we should be doing is reinforcing it. Now, in reality, the physician comes in, they talk to him, they give them the information. So we will be doing a ton of reinforcement. And so I'm not telling you that you're not going to have to be like, yes, no, this is what's happening, this is what's happening, this is what's happening. You will still have to be doing a lot of reinforcement about the surgical procedure itself. This is how it's going to go in, this is how the surgery is going to be going in. But you can still call that physician and have them come back in if this patient just does not understand this. They're the ones that give this information, because we're just signing saying that they've been informed and they're the right ones. Now, that being said, here's the information that is important for you after that. Who can give consent is important. So they must meet these legal requirements to give consent. So first of all, the persons that give consent, you must be 18 years or older in most cases. This is not every case, because there are going to always be these exceptions. So typically 18 years or older, there are going to be exceptions. If a person is pregnant and they're giving birth, there's an exception. So say a person is having a C-section because they're pregnant and giving birth, those patients are going to be able to sign consent. A lot of times emancipated minors can sign consent because they have a legal document. But most of the time, if they are under 18, a parent or legal guardian is the person who signs consent. So they have to have proof that they are the parent or legal guardian. If a patient is over 18 but they are mentally incompetent to give consent, then the person who is the next of kin is the person that gives consent, unless they have a court-appointed or chosen power of attorney or court-appointed power of attorney. It is the next of kin. So the next of kin, who is the next of kin, is important. So the next of kin is, first of all, their spouse first. So if you are married, that's your spouse. It does not matter if you're separated, It does not matter if you hate your spouse. It does not matter if you are still married legally, unless you have if you have a legal power of attorney, your spouse will be your next of kin. So just FYI, if you do not like your spouse, get you a power of attorney appointed if you do not want them making your medical decisions should you become incapacitated, okay? Then if you do not have a spouse, your next of kin becomes all of your adult children are your next. So if you have no spouse and you have no adult children, your next will be your parents. So your parents will be the next people that have the decision. So adult children, and it's all adult children, by the way. So they can like override each other. I will tell you that how it normally works is they will just kind of start dialing up and getting consent. They really, if they're like, they figure out, they get the numbers, they will call someone. But what happens like in a DNR type situation is they can override it, but once they get consent from the adult children, they will use that as informed consent to get blood. So then the other thing to remember is that you do not want to give the patient any kind of psychoactive medications before you get consent. So there's usually a protocol in place in each facility, or sometimes it's the state will have different orders, but typically it's anywhere from 2 to 6 hours. I believe in Arkansas that it is related to the timing of the medications, but typically it's usually about 2 hours. So you do not want to, you want to get the consent and then you can give them any kind of pain medication. And most typically this is what happens is you'll see somebody give a patient pain medications in ER and then the physician will order something and they're like, oh crap, they ordered something. And so what will happen usually is the patient will sign consent and then the next of kin will sign consent after them so that they will get both consents. But that is not ideal in any case, and it's really not what you want to have happen when you have a patient that is completely with it. And I also want to say that if you have a patient that has an advanced directive, and a power of attorney assigned, that does not mean that that power of attorney automatically gives consent. They only give consent at the point that the patient no longer is mentally capable. So that does not automatically mean the patient does not give their own consent. And I have had so many fellow nurses that get really confused by that and try to get the patient's power of attorney to give consent. I'm like, the patient's completely alert and oriented, and we don't need to get them in here. The patient's completely with it. I'm not gonna have their power of attorney called. Why would, they just have them assigned in case of, which is really the point of the whole situation. So also be very clear about that when you tell someone that you have a power of attorney, that you're completely, capable of making your decisions. You have a power of attorney in case you're not capable of it as well, if that ever were to come up. That is more of a you issue and not a preoperative issue, but that's just an FYI. I know I kind of referred to this before, but when I refer to it multiple times, it may mean that it's important. So you implement the skin precautions. Patients, you want to teach the patients to wash, scrub, or shower the surgical area with antibacterial solution the night before and or the day of surgery. The antibacterial solution we typically use is Hibiclens. That's just more of an FYI for clinical setting for you to know what we're talking about. And you will actually see people have this ordered just for Hibiclens baths for other reasons, not just for OR reasons, on the floor sometimes. And you may be the one administering this for patients that are not able to do this for themselves at home. And once again, clippers only to prep sites. Absolutely no razors, because you can have small nicks in the skin, which microorganisms can get into and settle into, which causes increased risk of infections. You do not want that near a incisional site, or, my guess that's what I mean, incisional site or open site. You want to maintain the NPO status for the amount for the procedure itself. It does vary. Sometimes you just have a local anesthetic and you don't necessarily need any NPO status, and then sometimes you have a general anesthesia where the GI motility is going to be almost completely paralyzed or completely paralyzed at that point. And at that point, when everything kind of is sitting there, you have that risk for vomiting and potential aspiration of that into your respiratory system, and that is no good. So we don't want to see that happen. All right, so that pre-op teaching, once again, that pre-op teaching focuses a lot on those post-op complications and how to prevent that. So exercises and physical activity. So we're going to focus a lot on how you have to get up and you have to move and you have to do all of this stuff post-operatively that you're not going to really feel great about, but you have to do it to prevent these things. And so that when we're bugging you and fussing at you post-operatively, it's going to feel annoying, but these are the reasons. And so that when we're doing it post-operatively, we're really just reinforcing it. We're talking about coughing and deep breathing. So you have to do this so that we are taking these deep breaths and opening up those airways so that we expand those alveoli so that we're not causing atelectasis. And we don't cause atelectasis, which can cause, the collapse of those alveoli, which can lead to pneumonia. We cough to get all that gunk out, which could lead to pneumonia if we left it in there. We do incentive spirometry, so that also expands that alveoli. It helps us to take those deep breaths even when we don't want to. So we open those alveoli up and expands them. We turn to keep that gunk from sitting in one place so we don't develop pneumonia. We do leg exercises. We also have SCDs post-operatively to prevent our blood clots from forming, leg exercises as well, and getting up and moving and walking as soon as possible, which should be here. I don't know why it's not. Because we want to prevent a blood clot from forming, a DVT from forming, which can then form into a pulmonary embolism, and a pulmonary embolism will travel, it travels into a blood clot, travels into our lung, which is a pulmonary embolism. Those 10% of those will result in death within an hour. So that's a very big deal. You don't want that to happen to a patient, letting them know the risk if we don't do these post-operative care, how we can prevent that from happening altogether by doing this care. The pain management, we want to know, we have pain medicines that we're going to have available for you. We're going to talk to them about the pain scale. On a scale from 1 to 10, what would you expect your pain levels to be? Here's the pain medicine that we expect to have available, whether they're going home or not. This is when you should take it at home if you're doing that. This is when you should ask for it here if you're staying here. Here's some other things that you can do for pain control, meditation or distraction management, or here's some wound or splinting, splitting your wound, especially if you have chest or abdominal. You hold the pillow against your wound if you're coughing or hiccuping or something. That will help keep those muscles from stretching, which can cause very severe pain, and that can keep that from hurting while you're doing that as well. The physical preparation, so understanding exactly what you're going through for this procedure, preparing for it. One of the things that you'll see is prepping for the procedure itself is getting marked for the procedure prior to, especially if first of all, you're going to get marked no matter what. So if you're having a gallbladder surgery, the physician's going to come in and mark that spot. But if you're having right versus left, the physician will come in and mark which arm, which leg, etc. It always gets marked. So that physical preparation is going to happen as well. But you're also going to be educated on this prior to and during. Monitoring during and after surgery. So understanding, like, as soon as you get in, this teaching starts happening. So before you get educated, but you're going to be told what's going to happen during the surgery, and you're going to be told what's going to happen when you wake up. So you're going to know when you wake up what to be expected. So you're going to have that education. So when you wake up and you're going to be in this room and confused, it's not going to be completely foreign. You're going to be like, okay, wait, this is, not completely new. I was told that I was going to be here. And then when they start telling you this, it's not going to be as scary because you're given this instruction before you're ever in that room. So also with the preoperative nursing care, there's going to be some administrations or holding of medications that you would have. So there are a lot of medications that are going to be held the day of surgery. So of course, you're not going to get your anticoagulants or antiplatelets the day of surgery. You're going to hold those prior to surgery. You are going to hold aspirin, antiplatelets, other antiplatelets at least 7 days, and anticoagulants at least 5 days before surgery. So that needs to be checked. We need to make sure any patient that was on that they held that, because if they did not, that's one of those things that could be oops, we need to hold surgery or, reschedule it. If you have a medication that is on call, it's very important. So on-call medications means this patient is about to go into the OR. So typically this means picked up while they're being picked up to head back into holding. So meds that are ordered on call to the OR are going to be given about 15 to 20 minutes prior to going into the OR. So as the patient is basically being wheeled back into surgery is when they're going to be given. So if you have a medication that is ordered on call and you're wondering like when is the best time to give this, it is when the circulator nurse is coming to get it. So if you say I'm going to come get the patient, when the circulating nurse is on the way to come get the patient, that's when it's a good time to give it. What you want, and the reason for this is you want it circulating in their system in the time when you start the patient in the OR. So antibiotics, you basically want that antibiotic going in their system when you have that first incision. So you start that antibiotic when the OR nurse comes to get them. You get them back in holding, which is usually about 15 minutes. You get them back in the OR, and that antibiotic is now going in their system. And it's the same thing with the other things. So anticholinergics, the antiemetics, the sedatives, the antisecretories, the opioids, these things will be circulating in their systems and ready to go at that point as well. And then I do have here, and I don't know if I just didn't have another place to put it, that I wanted to say that make sure that you also educate the patients that when they come out of the surgery, if they have a general anesthesia, that they're also going to typically they're going to have a pretty sore throat because they're going to have that tube down, and it does hurt to have that kind of scrape down into down their trachea. So often they wake up and their throat feels very sore from that whole trauma of the ET tube going down in their system. So when they wake up, it's very typical they're going to have like a hoarse voice and a very sore throat from that ET tube being in place for a while. And so not to feel alarmed from that, and that it does get better after several hours. All right, so preoperatively, you want to make sure that you detach anything that's removable from the patient. You want to remove nail polish so that you are able to get a good pulse ox on the patient's makeup so that you're able to see their true skin color on their face so you can recognize any changes. Hair pieces, and really one thing, you just don't want them falling off, but really the main thing is that there may be like hidden metal or anything like that in the hair pieces. You want to remove any kind of prosthetics and metal items. Prosthetics would be stuff like hearing aids. You could have people that have prosthetic legs. You have people that would have dentures, anything like that. Metal items could be their glasses, their rings, any kind of jewelry, any body piercings. And let me tell you, people have piercings, and those people, more people than you would think, and people that you would never think had body piercings. So you do need to ask about everything. Do you have any body piercings, including genitals, nipples, etc.? People have body piercings and they would surprise you. The metal causes shock sparks, especially with the level of oxygen, and we have electronic or electric cauterizations in the OR, and fires have happened, and I've seen sparks from things, and I've had stories that I haven't seen from like big fires that have happened with it as well, from people that I've known, but I haven't actually seen the fires. I've just seen sparks. So it does happen, and it's happened a lot, and it's there for a reason. Now, sometimes patients will have, like the hearing aids, the glasses, they will leave those in place because they need those to hear or see, but it still needs to be communicated very closely with the OR team so that they know exactly what is there, so they can take those and take those off before the patient is sedated. Indicate any presence of implanted device, and especially something like a Metaport, central line, or really important one would be like a pacemaker or a defibrillator. Like, it would be super important to know if a patient had defibrillator so that we know if that potentially would be going off in a patient, if they needed defibrillated. Urinary preparation. So most of the time, you want to avoid having to put urinary catheters in patients when they're going in for an operation. So if the surgery is short enough, or if it's not needed for another reason, the patient will typically just be asked to void prior to surgery, and then they will void. You will ask the patient to void prior to going back into the surgery room, or going back into holding, and then that is kind of the end of it. And usually indwelling urinary catheters are not placed until they get into the OR, but if it's ordered, they will place that in pre-op. You will want to make sure that you raise your side rails before you travel with your patient, and before you give your pre-op meds that would cause any kind of change in mental status or drowsiness, etc. And you have a pre-op checklist that must be completed prior to sending the patient on to the OR. And you must document all interventions and patient responses. Remember, if you do not document it, it did not happen. And here's just your pre-op checklist. So you have your patient information, your arm bracelet, your ID band on, your allergy band with your documented allergies. And I want to correct something that I said, and I have to go back and figure out where I said it on. The latex allergy, I think I said it the last case, and that makes no sense because it's the first case, because otherwise you would have had the cross-contamination with latex allergies from the previous cases, which was silly. You have the separate kits. I know anesthesia has a separate latex kits, and we have different latex kits for all the OR equipment that have no latex in them, and you would want to do it the first case of the day, and I'm almost positive I said last case on the previous slide, so I'll go and make a little note of that. Medical information for the patient needs to be on the chart. Remember, history and physical must be on the chart. The only exception to that is that emergent surgery where it's kind of a life and death situation. Obviously that trumps that. Lab studies, ECG, chest x-rays, they're completed as ordered. We've discussed that as needed and reviewed those and discussed those as needed with the physician. Surgical information is all available. We know the procedures. We've identified the site by the surgeon, so they've looked at it. It's been identified on the surgeon. They've marked that on the patient. The consent has been signed, and that's both the surgical and the anesthesia. The OR prep has been completed, so the surgery's oh my gosh, the OR prep has been completed with the patient the day of the surgery. The next of the kin, the family has been located. The hospital gown is on. All items have been removed, as we talked about. And then in the next slide, there's this lovely little picture for prior to the transfer of the surgery, where you see all of these lovely little checklists that you need to know have been completed as well.